Hello, my name is Sam Ord. I'm an ICU doctor at Nepean Hospital at Sydney, and this is a lecture on intravascular volume and fluid responsiveness assessment with focused cardiac ultrasound. And this is a lecture which is part of the Australasian College of Intensive Care Medicine focused cardiac ultrasound curriculum series. In the other lectures that we've done as part of this lecture series, I've tried to keep them as sort of simple as possible, and I've tried to avoid bringing in my own personal bias and just sort of present facts and sort of imaging tips and tricks and potential pitfalls, I guess. I don't think I'm going to be able to avoid bringing my own personal bias into this lecture. When I started learning ultrasound and I sort of first started attending the lecture courses, there's a lecture on fluid responsiveness assessment with focused cardiac ultrasound, and it always came across as pretty simple and simple to do, and it gave you all the answers. I think this simply just isn't the case. I find assessing volume assessment and fluid responsiveness in the critically ill, I think it's very challenging clinically, and although focused cardiac ultrasound is maybe presented as an answer, I just don't think it provides that. What I do think it does is I think it helps maybe provide confidence to your findings on clinical assessment, and that's because both are probably pretty good at trying to assess volume status and fluid responsiveness when it's at the extremes. So with focused cardiac ultrasound, we can look at the inferior vena cava, and we look at the heart-lung interactions, and essentially we just look at the size of the inferior vena cava and how much it changes with breathing pattern. We can also look at the left ventricle sort of end-systolic size, and we sort of estimate what the end-systolic volume is. And through these we get an idea of what someone's volume status is. But as I said, I think it's only really good at the extremes, and I think it's probably got about the same sensitivity and specificity as clinical examination in my experience. I think it's important to do serial measurements if you're going to be using focused cardiac ultrasound to help with this, and there are better ways of doing it, but that involves using Doppler and things like a passive leg raise, and those are really for me in sort of more of the advanced imaging status. And you've got to be able to be good at doing the sort of simple sort of 2D or B mode imaging of the inferior vena cava and assessing that left ventricle size before you can move on to these. So just in this lecture, I'm just going to be focusing on the two-dimensional imaging sort of processes, and that's assessing the inferior vena cava and the left ventricle size. And as I said, I don't think it's perfect. I think it helps you at extremes. I think it probably backs up what you're already going to assess clinically, and it therefore maybe provides a little bit more confidence to the conclusions that you come to from clinical examination. So the inferior vena cava, it is normally less than, say, 21 millimeters in size and greater than 10 millimeters. And essentially, if you're sitting outside of those ranges, you're going to have a small inferior vena cava if it's less than 10 millimeters, and you're going to have a large or plethoric vena cava if it's greater than 21 millimeters. What we're trying to assess is looking at the inferior vena cava through sort of subcostal imaging. We can have a look at how the inferior vena cava size changes with respiration. And when you are spontaneously breathing, or with a spontaneously breathing patient, as they breathe in, you're going to be decreasing your intrathoracic pressure, which is going to cause a decrease in your right atrial pressure, and that's going to cause your diaphragm as well as going to be pulled down during inspiration, and that will increase your intra-abdominal pressure. And there's also a sort of direct effect on the inferior vena cava. As the diaphragm comes down, it can actually cause some sort of a compression of the IVC. And through that, we can see that if the IVC during spontaneous breathing, it collapses with inspiration. And the opposite is the case if you are mechanically ventilated. And when I say mechanically ventilated, I mean fully mechanically ventilated. So that's a patient who's deeply sedated or paralyzed, and they're not making any spontaneous breathing efforts, and the ventilator is performing all of the respiratory effort. So during insufflation, the reverse is going to happen. So you're going to see the IVC collapse with expiration in patients who are fully mechanically ventilated for the reasons we discussed above with inspiration in a spontaneously breathing patient. Now the classic sort of the classic document that sort of describes talks about the inferior vena cava collapse with inspiration is it comes out of the ASE, or the American Society of Echo recommendations for right heart assessment, and I use this a lot when I'm trying to sort of estimate pulmonary artery pressures, for example. And it is good at trying to assess what right atrial pressure is, so that they've got this wonderful table, and sort of similar things are banded around to maybe talk about assessing for fluid responsiveness. And I think I'd just try and encourage you to think that these are maybe sort of they're related obviously, but they're two separate things. You know, one is assessing right atrial pressure. And we know that the IVC assessment in patients who have sinus rhythm, it's pretty good for trying to estimate what your right atrial pressure is. But we also know that trying to use your right atrial pressure to assess someone's volume status or fluid responsiveness is not fantastic, and there's some very good evidence to show that that's the case. So I think it's important to try and remember that these are two separate things, and right atrial pressure assessment is not good for assessing fluid responsiveness. And the reason behind this maybe can be described by some of these curves. So this all comes from Guyton, who assessed these very elegantly, and you've basically got different kind of curves here for venous return and for cardiac output. And what Guyton was trying to describe with these curves is trying to show that where the curves intersect between the curve of venous return and the curve for cardiac output, that is where your central venous pressure, or your right atrial pressure, is determined by. And what I think is maybe sort of shown by these curves is that you've got, you know, that the central venous pressure can be it can be very variable, and that's going to be dependent on both your cardiac output as well as your venous return, and those are going to be dependent on many, many different things, not least sort of underlying cardiac function, but also adrenergic tone, venous compliance, venous resistance, and many other such things. And I'm sure it doesn't take too much imagination to imagine that these are in a sort of an extreme state of flux when someone is critically ill and you've got maybe increased adrenergic tone, or indeed if you've got that patient very sick and then you intubate them, you get that loss of the adrenergic tone. I think it's just worth bearing in mind that central venous pressure is there's multiple determinants for it, and that's probably one of the reasons why it's quite difficult to try and determine whether someone's fluid status based on CVP is. So let's talk a little bit now about how to image both the IVC, and then we'll move on to imaging the left ventricle. So the IVC, the inferior vena cava, it can be assessed from different places in the subcostal region. It can be assessed laterally or from the subcostal position just under the xiphisternum. I think probably that under the xiphisternum, the subcostal region is probably the best recognized, and it's certainly the most researched position, and it's what the ASE guidelines and the British Society of Echo and the Australian Society of Ultrasound and Medicine, all the big sort of ultrasound groups that I review their literature, it's where they all recommend that we should be assessing the IVC. I think it's essential that you try, and if you are using it in a different place, I think that's okay, as long as you understand that there are there are certain intricacies involved from each position that you're imaging it from, but you just do the same thing again and again and again, so that you have a certain repetition to your imaging. It is essential, no matter where you're imaging it from, you have to see that IVC right atrium junction, because the aorta is very close to the IVC and you do not want to mix it up, because obviously you can have a small and a collapsing IVC that can sometimes be difficult to image, but if you're imaging the aorta, you're going to be imagining that you've got this plethoric dilated IVC. I think maybe it's worth saying that if your clinical acumen is completely counteracted by your echo findings, you've got to maybe assume that again there's maybe potentially some imaging problems that you've got. So you've got to make sure that you're imaging the IVC correctly. What the ASE guidelines recommend is that you measure the IVC from the subcostal position, and that you measure it 1 to 2 centimeters from the right atrium, and you have to see the IVC RA junction, and you try to get that IVC in a nice sort of big longitudinal view. And as I said, there are other ways of doing it, but just as long as you try to adhere to the same protocol each time, that ensures a reproducibility. So this is sort of a classic picture, I guess, of what we're looking at here. So this is with the echo probe in the subcostal position, and we are, with the marker on the probes, we're pointing upwards at about the 12 o'clock position, and you get this kind of nice longitudinal view to the IVC. And what's essential is that you see this IVC-RA junction, because then you know that you are imaging the inferior vena cava. And then we're looking about 1 to 2 centimeters up from the IVC-RA junction, and you measure perpendicular. So again, really important to measure perpendicular across the IVC. And what we classically use is called the collapsibility index, which is where you take the maximum diameter, you watch how it changes over the respiratory cycle, and then you measure the minimum diameter, and you divide that by the maximum diameter and use that as a percentage. And this will give you an example of what the collapsibility index is. So this is something that is this is an image that's easy to get, and what I'm going to try and persuade you to see here is that this is the aorta. This is not the IVC. What we cannot see here is the IVC-RA junction, and try and persuade you that this is the aorta that's just sort of bypassing, going sort of behind where you see where the heart is contracting. And what's happening here is we're essentially just imaging too far left, and we need to be imaging over to the right side a bit more to try and get that IVC. When you're imaging the inferior vena cava, it's important to try and get that maximal diameter. So just the same as if you're trying to assess the LV size in any other kind of imaging, we talk about sort of fanning through that cylindrical structure to make sure that you've got that maximum diameter. The same thing goes for the IVC. So you've got to watch for what we describe as translational error. So we want to be imaging right down the gun barrel of that IVC. We don't want to be off axis, either at an angle or indeed just completely off to one side, because that will underestimate the actual size of the IVC, and that's what's known as translational error. So yeah, just fanning through the IVC, get that maximum diameter. And it's difficult because when the patient breathes in, you're going to get movement of the IVC, and I think it's important to look out for that to make sure that you're not getting this translational error. In terms of the groups of patients that you can image, there are essentially two groups. You've either got the patient who is fully spontaneously breathing, or you've got the patient who is fully mechanically ventilated. So in the mechanically ventilated patients, most of the studies looking into sort of volume status and fluid responsiveness, assessing the IVC, they're using patients having small tidal volumes, about 7 mils per kilogram tidal volume, so sort of the Ardsnet criteria. And I think there's a sort of a general trend that we're in patients who've got respiratory issues, who are intubated, or patients who are intubated for other reasons, we're sort of ventilating patients at a similar kind of sort of small tidal volume respiration settings, and so generally we've got people around about the same settings most of the time. Spontaneously breathing patients, as we discussed, there's also good evidence, there's also good research that's looked into this of the IVC and the volume assessment. But intubated patients who are making spontaneous breathing efforts or they're on pressure support, there's just simply no validated measure at the moment. And that's because you're going to get such big changes in your intrathoracic pressures that are changing with the breathing, and whether you've got a supported breath or not, that it's very difficult to make any kind of solid recommendations based on that. So essentially, when you've got a patient who is making spontaneous breathing effort, the IVC is not a good way of assessing their volume status, and I think essentially it's even going to help more at the extremes again. And this is what it looks like. If you have a small IVC that's classically less than about 10 millimeters here, and you can see it's fully collapsing during the inspiratory cycle, this is a sign of a patient who's potentially hypovolemic and would respond to a fluid bolus. And this is as compared to someone who's got a very plethoric or fat IVC, and here you can see it measuring 23 millimeters, and it's not collapsing during the inspiratory cycle or during the respiratory cycle, and that is a sign of someone who is maybe hypervolemic and would not respond to a fluid bolus. But there are many confounders to someone who's got a big plethoric fat IVC, And that would include patients who've got increased pulmonary vascular resistance from any number of causes, including long-standing pulmonary hypertension from COPD or left-sided heart problems, patients who are intubated, who are on high levels of positive end-expiratory pressure. If you've got a PE that's in there, or any kind of these sort of reflex mechanisms that we have which increase up your pulmonary vascular resistance, which is our where we get these reflex pulmonary vasoconstriction from hypoxia, hypercarbia, ratelectasis, which are frequently seen in the critically ill. Also, if you have any kind of RV dysfunction, which can come from sepsis or ischemia, RV dysfunction will lead to an increased right atrial pressure, or if there's significant tricuspid regurgitation or any kind of intracardiac shunt. Any of these are going to cause dilation to your inferior vena cava. And as I'm sure you're seeing from looking at that list, these are extremely common findings that we see in the critically ill patient every single day. So what does it come down to? So I'm not going to mention a lot of the evidence. If you do want to look into any more of the details behind this, have a look at the references at the end of this lecture. And in particular, there's an online lecture done by a guy called Justin Bowrer, who's one of the intensivists at Royal North Shore. And he gave a lecture at the SMAC conference in 2013. He gave an amazing lecture discussing this. And if you want to learn more about it, I highly recommend listening to that lecture. This is basically a summary of what he says, and it's also what I do in my practice. And that's essentially, I have two groups of patients. I either have my spontaneously breathing patient, or I have my fully mechanically ventilated patient. If I have my spontaneously breathing patient, I just simply don't think there's evidence there to suggest that this is a valid tool to use in that yet. If you're spontaneously breathing and you have a small inferior vena cava, less than 10 millimeters, and it collapses more than 75%, that for me indicates that someone is, with as much certainty as you can have, they are hypovolemic and they will respond to a fluid bolus. And that means that their cardiac output will improve if I give them a fluid bolus. If they have a great big IVC, greater than 20 millimeters, 21 millimeters or above, and it does not collapse, then they are likely hypervolemic and they will not increase their cardiac output if you give them a fluid bolus. If you have a patient who is fully mechanically ventilated, I say that maybe the evidence would suggest maybe you can have just a little bit of a bigger IVC diameter, maybe 12 or maybe 14 millimeters. And if the collapse is greater than, if they've got any kind of collapse, then you can say that maybe hypovolemic and they'll respond to a fluid bolus. And again, if you've got a big plethoric, non-collapsing IVC, they're likely hypervolemic and will not respond to a fluid bolus. I do think that you need to do serial measurements. I do think you need to marry this up with your clinical acumen, and you've got to take it in clinical context, and you've got to make sure that your imaging is okay. But I do find this a fantastically useful tool in patients who are spontaneously breathing or fully mechanically ventilated, and it's something I use all the time. And what it probably does is just provide extra confidence to my clinical assessment as much as anything else. So what about the left ventricle assessment? I'll just provide these two examples. So I'm looking at the size of that ventricle at end systole. And again, to repeat something that we've said over and over again, this is a complex three-dimensional structure that you are imaging with a two-dimensional imaging tool. You must assess it from all kinds of different angles. Sometimes one view is not possible for whatever reason, and so you just got to use all the views that are available to you and try and make an assessment. I think probably the short axis view is probably the most useful from my point of view because it's less prone to sort of translational error. And essentially what we're looking for is this kind of small, tiny little left ventricle end systolic area or end systolic volume, and what we call a kissing ventricle sign, where those walls are actually sort of coming together and almost touching. And you marry that up with your inferior vena cava assessment, and you can get an idea that someone is very hypovolemic. And now I'd ask you to compare that to maybe this image, which is where you see someone with a great big ventricle. Here's 96 millimeters, huge internal diameter in diastole, and that ventricle's not contracting very much at all. This would suggest to me that this patient has maybe a raised left ventricle end diastolic pressure, and they've got this large end systolic volume, and fluid responsiveness is not going to increase up this patient's cardiac output. And if this patient is hypotensive, they need inotropic support rather than a fluid bolus. So, in conclusion, I think fluid status assessment is hard clinically, and it's hard with echo. I think cardiac echo helps at the extremes, or focused cardiac echo helps at extremes. I think it can be better if you're using more advanced methods, but that is not as part of this lecture series. You must have clinical context. And if you are going to be assessing the LV, again, you're assessing it from multiple views to try and get your assessment of it. There are other ways to assess it as part of the advanced imaging, and I hope to maybe help out you with some of that in further lectures. But with the focused cardiac echo, I think we just need to stick to assessing the IVC, looking at that left ventricle, and understanding the limitations that are involved with it. And it's very, very important. Let's just put it in clinical context. So here are the references. There are some fantastic resources in here. As I said, in particular, Justin Bower's lecture, as well as some of the MCRIT podcasts done by some of the guys in America. And I highly recommend you have a look at some of those if you want a bit more detail. Thank you very much indeed.